right, and just on to our next speaker, and we have Dr. Gina LaQuesta joining us. Dr. LaQuesta is an adult allergist and immunologist working in Halifax at the Halifax Allergy and Asthma Associates Clinic, as well as an assistant professor at the Faculty of Medicine, Dalhousie University. Her special interests include inborn errors of immunity in adults, hereditary angioedema, chronic spontaneous urticaria, and severe asthma. Thank you. Awesome. Thank you so much for joining us.
Thanks, David. Morning, everybody. So I'm always happy to come and talk to this group. It's been a couple years. It was pre-pandemic, so even a couple years before pre-pandemic. I think I remember bringing my daughter with me at that time because we had to rush to basketball afterwards. So it's probably been at least 5 to 6 years afterwards. I wish all of my immunodeficiency patients could come along to this. I think it's so valuable, especially to hear the patient stories. My talk's not that valuable, I'm going to be honest. And if I do this again, I don't want to speak after Ashley next time. Your slides are great. Your story is passionate. Everybody should hear that story. In any event, I don't want to get us behind time, and so I'm going to get started. Do I just press enter? No? Arrow?
There's a bit of a delay there.
Okay. So I've been asked to talk about what's new in the care of adults with immunodeficiency, and I've been given 20 minutes. So I kind of picked just a few little topics. There's a big delay. Am I pressing enter? Spacebar? Okay. These are my disclosures. I work with any pharmaceutical company that will help to educate and support patients. So that's my impetus for doing that. So we're going to talk about the diagnosis of immunodeficiencies. The big topic this year is the new immunoglobulin treatment that's available. A little bit about vaccines. I get questions about this every visit, I think. And we have to talk a little bit about COVID in Nova Scotia. So what are we talking about? So we all know how immunodeficiencies present, but how do we identify these patients? How am I getting these referrals? So hopefully we want other physicians, primary care physicians, emergency room physicians, other specialists that patients get to see, ENT, respirology, etc., to recognize something's just a bit off here. People are getting too sick. But we have criteria that we educate these other practitioners about to say, you know, pay attention when you see this. So 2 or more new ear infections in a year, 2 or more new sinus infections that we can't blame on allergies, 1 pneumonia per year for more than a couple years in a row, chronic diarrhea where there's weight loss. I know everybody gets diarrhea, but really where they're losing a lot of weight with that, recurrent viral infections, need to go on IV antibiotics to clear an infection, big abscesses, super sick, needing admission to the hospital, persistent thrush or fungal infections in the throat, infections with a normal harmless bacteria that are quite severe, and of course a family history of primary immunodeficiency. So this is what we look for, and we're definitely missing a lot of people, right? Especially in those who have severe recurrent respiratory infections where we blame it on smoking or COPD or even severe asthma or sinus infections where we say, you know, oh, they're smokers, they're working in poor air quality, etc. Some of those individuals actually have undiagnosed immunodeficiency, and we can really make an impact if we find them. I was looking at this morning and I realized this slide is not set up properly. So the new buzzword, you know, we all hear the word immunodeficiency. It makes sense to us. You are deficient in your immune system. But the new buzzword is inborn errors of immunity, because not only is it a low immune system, as Ashley said, sometimes patients have dysfunctional immune systems where they're getting autoimmune conditions. So their immune system veers off and does other weird things to their body as well. And so primary immunodeficiency and inborn errors of immune system are kind of the same thing. Parts of our immune system are just missing or they're not working properly. There's been over 450 different conditions that have been described. And if you think I know all of them, you are severely incorrect. It's impossible. Many are very, very, very rare that many immunologists will never see them. that's how rare they are. But in adults, which is where I practice, it's primarily related to antibody deficiencies. So common variable immunodeficiency, IgG subclass deficiency, or complement deficiency. So those are the common ones that I see. You're going to hear now more about secondary immunodeficiency, and we're talking a lot about that in our world. And these are individuals where it's not their inherent immune system that's the issue. It's because of either medications they are on, in particular, some hematological cancers and abnormal conditions that way, where their treatments are affecting their immune system, or just the inherent problem with their immune system causes them to have low immune system. So they need treatment for both. With the advancements in these conditions treatments, we're seeing more and more and more of these. So you may meet other individuals who say, yes, I have an immune system. I also have multiple myeloma. I'm also on immunoglobulin treatment. At the end of the day, we do treat them the same way, but just so you know, that's where they're coming from. It may be a little bit different than yours. Same thing with autoimmune disorders. I see them. So I cannot take credit for this. But it's something that you should all know about, and I will certainly be approaching our patients about this. So this stems from the Canadian Immunodeficiency Network Canada. So it's a group of physicians who are immunologists primarily. There's some infectious disease doctors there who treat patients with inborn errors of immunity. We want to form a registry, and registries are so important with rare diseases. So what is a registry? It helps us to look at who are the patients who have the various diseases, how did they present, what were their test results look like, what is their family history, what are other conditions that they have, what are their treatments, what are their side effects, what other conditions develop as their disease goes on. Clearly, all of this is anonymized. Nobody wants to zone in on, I'm going to pick on you, Ashley Hickey, to say what does Ashley Hickey do, but we want to look at things as a whole. Many countries have this, and we may even tag on to an international registry, because how are we going to learn about rare diseases when me, Dr. LaQuesta, only has a subset, and I don't know what everybody else in the country looks like. So essentially, there will be some work on the part of the patient where we're going to ask you to input data as to what's your background, etc. There will be a lot of work on study coordinators and physicians and nurses to continue updating that data once a year. And it's just a good way to track it. So stay tuned. You probably will be contacted about this. It's purely voluntary. Nobody has to do this, but I think if you're sitting in this room, you probably will want to volunteer and participate. The IWK is further along than the adult part. It is a rigorous research protocol. It goes through a research ethics board to make sure everything's on board. Your data is private. Nobody's using the data for any weird purpose. So just so you know, that's coming. So let's move on now and talk about the new treatment option. So background, everybody is aware of this. So immunoglobulin, it's a blood product used in patients with some immunodeficiencies, not all of them. It replaces the part of the immune system that seems to be defective, and its whole goal is to prevent recurrent or serious infections. We have options now for treatment for this. So there's intravenous immunoglobulin, which you get at the hospital, but now there's some home treatments. We've had Cuvitru or Hizentra available for at least 10 years now, maybe a little bit longer. And now we have HyQvia. So that's what we're going to talk about. So what are some factors that we take into consideration into how we're going to choose which type of product you use? So I made a pro-con list. So IVIG, what are the pros? It's less frequent dosing every 4 weeks. You get a fast response. You can increase your levels quite quickly. You get to see, you touch base with a nurse every 4 weeks at the hospital. And there are social aspects. Maybe you are on the same day as your immunodeficiency buddy. I don't know if you guys have those, where you get to socialize, you meet the nurses. Some people get that day, that afternoon where you get to sit, you zone out. Now there's Wi-Fi, you can watch Netflix, maybe the nurses, if you're lucky, they might bring you a cookie or something that day. If somebody offered me a day a month where I could do that, I just might pick that. I don't know. What are the cons? So clearly it's an IV poke, and you can imagine IV pokes once a month for the rest of your life. Your veins kind of complain after a while. Systemic effects are more common. So people can get anything from allergic reactions, which can be quite unnerving and scary. You can get severe headaches. You're tired for a couple of days after. So not only do you have to miss that day of work, but then you might not be your most productive a couple of days after that. You are at the mercy of the hospital schedule, and those chairs, I know here in Halifax, they are at a premium. So, can you get every 28 days exactly? You might not be able to. It's time away from school or work, family life. It can take a while, up to 4 to 6 hours. You have to park at this hospital parking, which is a pain. So it's not the most logistically friendly. To be able to do it at home, so subcutaneous immunoglobulin, so no need for the IV access. It's a flexible schedule. You can do it on your own time. I always mention my patient who every Sunday, NASCAR driving, that's his Cuvitru date. You can travel with it. It's a bit of a pain, but you can carry the boxes with you and take it on your trip. For those who are lucky enough to winter in Florida, they can take the whole 6-month supply with them and off they go. You don't have to go to hospital. You feel like you can take control of your treatment. In some ways, there's a steadier level rather than a big peak and then it falling off. That's good for some people. And there's definitely less systemic side effects. You're less tired, less headachy. You can get a little bit of local irritation where you give it in your belly or your leg, but that's usually manageable. What are the con sides of the subcutaneous? It's multiple injection sites. Again, you can get the injection site discomfort. I say once a week. Some people need to do it a couple times a week. And again, you need to be able to store the product at home. So again, if we look at the different types here, so IVIG, you're tied to the hospital with a nurse every 3 or 4 weeks at the hospital schedule's mercy. And again, it can be 4 hours. Sometimes people have to go 2 days in a row. At home, you can do it anywhere. The slide says in your villa in Italy, if you're so lucky. Your patient or your family can do it. You do need some degree of body fat to get in there. And it's based on your schedule. So the current subcutaneous that we're doing now, anywhere between 20 minutes to an hour. The average is an hour for sure from start to finish. I don't think I have anybody who can do it in 20 minutes. Maybe in the pediatric world, their doses are smaller, maybe. With the new product that we're giving, facilitated SCIG, I think initially it was like, oh gosh, of course I only want to do it every 4 weeks. But you need to know you trade off that it is a longer time putting it in. So you need to ask yourself, do you want to do once a week for an hour, or do you want to do once a month for, I actually think it's a little longer than that, more than 2.5. It's probably more like 3 to 4 hours, especially in the beginning. So what is this new product? And I got the little thing on the bottom, this marketing thing, which I just pulled off the internet. Buy IV infusions, high sub-Q immunoglobulin infusions. I'm glad I don't work in marketing. You should work in marketing, Ashley. In any event, so what is HyQvia? So we think about it, it's called facilitated SCIG. So something is helping you to administer the subcutaneous immunoglobulin. And what that thing is that's helping us is something called hyaluronic acid. Hyaluronic acid is in every beauty product out there. You're going to see that word a lot. But for our purposes, what it's doing is it's breaking open the space where you administer your immunoglobulin. So you have more of a space to put more of a volume in. And that's why you can give more at a time. Fewer injection sites. So if you're a 4 injection site with your Cuvitru, with your HyQvia, it could be 1, probably 2, to be honest. And keep in mind, it's been in the US for 10 years now. Like, this is not a brand new product to the world. They have lots of experience and continue to have good experience with it. I don't know if you can see that picture. When you get your product, it's gone. You'll get your immunoglobulin, and then attached to that is the little bit of the hyaluronic acid that goes along with each bottle. So this just shows how it can open up that space, and then that space is open for about 24 to 48 hours. So again, if I lay out the difference, IVIG once a month, whereas Cuvitru or Hizentra, sorry, in terms of the sites, it's one site, Cuvitru or Hizentra, it's a couple sites. HyQvia, it's typically, I don't know why that says 13, but I think that's the thing didn't go up where it should be. So it's typically one, I'm gonna say sometimes two. The frequency, IVIG is every 3 or 4. Cuvitru or Hizentra is going to be sometimes daily. I don't have many people doing daily. I can say a couple times a week to once a week. Some people every 2 weeks, but HyQvia, the aim is to do it less frequently. So every 3 or 4. In terms of the peak level, et cetera, I don't really think that's an important decision point for people to think about. I think, and again, that whole administration, do you want to do it yourself or do you want to do it at the hospital? I will say I see a big advantage of those patients still going to hospital. And even if they still want to do it at the hospital, it's vein saving, right? And arguably maybe a little bit shorter than the IV. So I will be looking to talk to people about switching that eventually. Remember how I said you get that opening up of the space and it lasts for about 48, maybe even 72 hours. So this is a picture example of somebody giving it. And when that space opens up, you will get some local swelling there, right? I'm not going to say it's negligible. It's definitely there, but it does dissipate over the next 48 hours. And again, if that's something that's important to you, you need to keep that in mind. I think I have another picture here of a man kind of side on. So it's there, and you can see it even happens in your legs as well, but it does get better with each infusion. In terms of efficacy, so how well does it work at preventing infections? I think it's really the same whether you do IV, Cuvitru or Hizentra, or also HyQvia. So I don't think that should be a decision point. Efficacy was similar over all 3 modes. I can't say one would make me choose more than the other. In terms of safety, you're looking at a completely different set of side effects, right? So for the IV, again, in the gray bar, we see the headaches, tiredness, some people get a low-grade fever, etc. With the HyQvia, it's far, far less. So who is a candidate to switch to this HyQvia product? Honestly, anybody, right? And I also want to make the point that nobody is forced to switch. This is purely patient choice. So anybody who's prescribed immunoglobulin can be offered this, whether you are on Cuvitru or Hizentra now and want to switch, or whether you're IV at the hospital. In terms of the dosing, we essentially just take whatever dose you're on now, think about what you would need over the month, and then we can translate the dose. There's an excellent patient program that will help teach. You have to be retaught. The pump's a tiny bit different, arguably. The setup is a tiny bit differently, and there's excellent nursing support who can come to you to help with that education. And again, I'm really looking forward to those people who are in hospital getting IV, because I really want to save their veins. I also see it advantageous for, I've been in practice for 20 years now. I'm getting some patients that are getting older in age who can't go to the hospital all the time. Maybe they live by themselves now and they're frail elderly. At this moment in time, home care does not support giving immunoglobulin in the home, which I think is ridiculous. We are fighting that. But I think if we can offer something like this where it's only every 3 or 4 weeks, I think that's definitely an option. So what's the process? Discuss it with your treating physician. Everybody's put into a patient program. It's still the same patient program that we use for Cuvitru. So it's the one-path program. There's excellent training that goes on, and there is a ramp-up schedule. And you get the same follow-up. You know, we see you however often, every 3, 6, sometimes once a year, reviewing your infection control, what are the side effects, and you still need lab work follow-up. If you switch from Cuvitru Hizentra to HyQvia, your lab follow-up changes a little bit, because before I would say get your IgG levels checked whenever. It didn't matter because you were dosing so frequently. If you switch to every 3 or 4 week dosing with HyQvia, my most important level to look at is a couple days right before your HyQvia dose. That's a bit of a change. So that's the typical ramp up schedule. We don't just on the very first day give you the full dose. We give you 25% and then slowly build it up. And the nurses are well aware as to how to do this. So it takes about 7 weeks to get up to the top dose where you're spread out to every 3 or 4 weeks. I will always aim for every 4 weeks. For people, I think we take into consideration, how do you feel? You know, are your levels dropping off too much? Do we want to increase your dose? Do we want to go every 3? There's a bit of nuance. So things that stay the same, it's still home-based, you still get a pump, the supplies are still figured out and covered, you will need training, you'll have one path support, you'll need to pick up your product from blood bank. It's every 8 weeks instead of every 12 weeks, and that has to do with the storage, and we don't want to waste a whole bunch if it doesn't work out for people, and you need to get the monitoring labs done, as we talked about. So I'm going to move on to our favorite topic, vaccines. So RSV, I had a lot of questions about this year, and we're kind of coming out of the RSV season now. So it's a new vaccine that was approved in Canada last year, Arexvy. Oh, you can't see. So underneath that picture is the celebrity endorser of Arexvy in the US. Not, well, actually, I think this was from Canada. Can you guess who it is? Wait, let them guess who it is. Who do you think is the celebrity endorser for Arexvy? It's a Canadian. Oh, Ryan Reynolds, I wish. Yes. Because I guess he's up there now, right? And I don't know, maybe he needs the money. I have no idea. I was surprised. I had no idea. I was just like looking for me. Anyway, so it's approved for adults age 60 and older. Just a little bit about RSV. So our pediatric colleagues are very familiar with RSV, and now we recognize it really can affect the whole population. But in our elderly, it can really knock them for a loop, just like flu can, hospital admissions, very, very sick. Its season is usually fall through till spring. If you look at the evidence, it really seems to have the most impact at minimizing severe disease in our very elderly with other comorbidities, so cancer, heart disease, diabetes, frail elderly, those in a nursing home. Single dose, protective for at least 2 winter seasons, maybe more. Best given in late summer or early fall. At this point, the timing of when it came out, it's not covered under any, I don't think, any provincial healthcare system, certainly not in Nova Scotia. It's expensive, but if you have a private drug plan, you can get it. In terms of side effects, it's a fairly decent tolerated vaccine. I can't say that there's anything to worry about. So in terms of immunodeficiency patients under the age of 60, you're not going to get it covered, unfortunately, right? And it's not indicated for you. Could you actually get it? Maybe we could figure something out, but it's not officially indicated. I think if you're above 60, why not, would be my advice. But especially if you have other health issues, especially respiratory health issues, I would add it to your vaccine list of things that you get. NACI, the National Advisory Council for Immunization, they haven't really come out with a statement on RSV yet. I think because it is still fairly new this year, so stay tuned. Don't know why. Doesn't want to advance. Click on. Oh, click on the presentation. Okay. Oh, how can I go back? Here. I think so. Pneumococcal vaccine, so it helps to prevent pneumonia. I think we're all aware all adults over 65 are indicated to get this vaccine. But NACI, so again, our National Advisory Council, they do recommend adults age 50 to 64 who are living with other health conditions, which I would include immunodeficiency, should be getting a pneumonia vaccine. And in fact, adults who are 18 years of age or older living with immunocompromising conditions, so I would say immunodeficiency, should receive a single dose of pneumococcal vaccine as well. So keep that in mind. We always review vaccines when we see in follow-up, but I do think there's a push for immunodeficiency patients to get it. The question I always get after that is, but don't I have a poor immune system? Am I going to mount a response, etc.? Agreed, your response may be blunted, but the risk from the vaccine is so low. I think if you get any response, the better. So I do recommend. Am I going backwards now? I'm going backwards. I'll just use this. That's okay. Okay, so COVID vaccine. All I want to say about this is there will be a fall COVID vaccine for everybody to get again. These vaccines are just not robust and long lasting as we want them to be. Plus, there's different COVID variations that are coming up, right? So be ready. There'll be a fall COVID vaccine. The usual recommendation is 6 months after your last COVID infection or COVID vaccine, but even 3 months is acceptable, just in case where you've timed your other vaccines, you don't want to miss out on the fall one. There likely will be a new iteration of it. So just make sure you get the up-to-date fall COVID vaccine. And whether you get a messenger RNA, Novavax doesn't seem to be as quick as getting the new up-to-date vaccines, but if that's available, I'm okay with that as well. And I have no preference, whatever you can get. COVID is still circulating, but definitely the lowest levels that we've had in a long time. If you test positive for COVID, it's that whole report and support online, report it, because then somebody will go through, make sure you plug in there somewhere that you have immunodeficiency. And the pharmacists, I feel in Nova Scotia, the treatment group here has been pretty good at recognizing you need the extra treatment, you should have access to that. So after May, which is as of today, Paxlovid can be prescribed by other health practitioners. So prior to today, it was only a certain number of physicians, pharmacists who really could prescribe it. It may be prescribed by other healthcare providers. We have not been fully educated what that means. If I can just write it and you can have it, I mean, in other provinces, certainly in the US, because I've had people tell me this, their doctors can write it and they can have it in their home, they can have it in their shelf at all times, right? We're not there. Coverage for the drug is going to be variable because that federal supply where they paid for it is not there anymore. So they're going to be relying on private drug plans. The pharmacare coverage is not well worked out yet, but I suspect it should be soon. The pharmacist is still going to be very, very very important in this process because there's a lot of drug interaction. So before, when they had control of it with that tight group who were prescribing it, we could trust that they were looking at everything. For me prescribing it, I'm definitely going to be relying on your pharmacist to kind of go through your meds and make sure everything's okay. So just so you know, that little bit is changing, and clearly the IV treatments, that's not going to be just your family doctor, etc. We will have to consult the infectious disease group. I think that's all. Happy to take any questions. Yeah.
For the new big option there, how similar is it to Cuvitru and Hizentra? I say
You mean in terms of the composition? Sorry?
What's in with the IV? Is it similar to the other two?
So, oh, sure. Yeah. So the question I had was, how similar is Cuvitru and Hizentra to HyQvia, especially in somebody who may have had adverse reactions to Cuvitru and Hizentra? So the immunoglobulin HyQvia is actually, I believe it's the same as GammaGuard. I could be wrong. Do you know, Karen? it's similar to an IVIG product that we have now. I think it's GammaGuard, to be honest. Yeah, the actual product, but it's subcutaneous. So I don't know. The other thing to think about is if it's subcutaneous, you might not be as apt to have severe reaction to it. I mean, you could always say, can we do test doses, before you fully commit to something. But yeah, I get it. Or pre-medicate. I don't know if it really is something you want to try, it may be, yeah.
We've actually
other
got a couple of questions.
Oh, sure.
online.
Yeah.
Okay, first one is, would an immediate higher dose bacteria be problematic for somebody previously diagnosed antibodies to IgA or blood transfusion?
Do you need me to repeat the question or?
Do you want me to?
No,
Or- I don't need to repeat the question. Oh, because it's online. So I think the amount of IgA in these immunoglobulin products is quite minuscule. I don't know what that patient's previous experience was, but I'm going to say it's minuscule, it's low. It wouldn't make me not want to try this product if it was indicated. Mhm. Mhm.
And the second question is, how often is the pneumonia?
That's a good question. So I think it depends on where you fit. Generally, every 5 years is what we think. In a healthy individual, we may check their titers before we automatically give it, but generally every 5 years. Mhm. And the pneumonia vaccines have evolved over the years. So if your vaccine was, I'm going to make this up, like 2 or 3 years ago, you may want to check with your practitioner because there's updated vaccines which cover more serotypes of pneumococcus that you may gain from getting repeat vaccines sooner.
Any other questions?
Not a trick question. With the new IQVIA, there's going to be a piece indication for with the dosing, are you able to break up how, like you said, like 3.5 hours? My only thought as a parent here, I don't think I get my daughter to sit that long. How do you, like, how do you?
Yeah, I mean, I've had many adults say that to me. I can't sit for 3 to 4 hours and do this. I want to stay with what I'm doing. So it's a good question. What I would say is stay tuned because it's a 20% solution right now. It's going to be a 10% solution. Sorry, opposite. It's going to be more concentrated later on so that the timing will be shorter eventually. But you're right, it's a consideration. You can do that, but if you're doing that, you might as well stick with what you're doing now, right? If you're going to be doing it more frequently. Yeah.
One last question.
Oh, sure.
Have you got one online? Nope. Awesome. Cheers, thank you so much.